Okay. So our first presenter is Evan Hoskins. Evan, are you here? And there's no Evan here. Evan, cataloging solutions to Northern health inequalities, a proposed literature fiction analysis. Okay, we're going to go on to the next one, and if Evan joins, we'll slot him in later. Leanne Flinton.
Hi, I'm here.
Hi, okay, I am going to back out and let you go ahead.
Okay, sounds good. I'm just gonna share um quickly here. Okay, so my name is Leanne and I'm a medical student. I'm presenting this presentation that I worked on with Dr. Kirsten Miller about pediatric emergency department visits and patient transfers throughout northern British Columbia. So just to provide a little bit of context about our project, we know that rural communities across northern BC face persistent barriers to pediatric care. These include long distances, limited specialties available in rural centers, and then, of course, our challenging geography and often snow. Our project sort of sought to evaluate pediatric emergency department utilization and then also transfer patterns throughout Northern Health. So we did a 5-year retrospective analysis from 2020 to 2024 using the Northern Health Pediatric Dashboard data. And we looked at pediatric ED visits and then transfers to higher levels of care, including UHNBC and BC Children's Hospital. So we found that across Northern Health, there's about 35,000 pediatric emergency room visits annually. And it was quite interesting that following the pandemic, the Northwest and Northeast in particular saw substantial increases in the number of emergency department visits, which was sort of a phenomenon seen on a broader scale across the country with the rebound respiratory season that we had following COVID. This slide also highlights the profile of pediatric specialist staffing, which, as you can see, differs quite a bit. So, in the Northwest, where their main center is Terrace, they have 3 full-time pediatricians, soon to be 4, where the Northeast relies on locum coverage since November 2024. That's only really covering 33% of the shifts between November 2024 and when we finished looking at the data. And then, as you can see, Prince George, of course, is our regional hub, and they have 7 full-time pediatricians that support the whole region. This slide here highlights pediatric transfers to higher levels of care, both at UHNBC and then BC Children's Hospital. And this speaks to the acuity of pediatric cases that are seen in emergency departments throughout Northern Health. So as you can see, transfers are quite high, particularly in ones going from Fort St. John to UHNBC. And we did include some preliminary 2025 data just to show really that substantial difference between cases that are coming from Fort St. John to UHNBC, given that they don't have the pediatric support in that community. And the map on the side just sort of highlights some of the communities that these children are coming from. So the white lines represent transfers to UHNBC and the black to BC Children's. And you can see that children are traveling quite far to receive the care that they're needing. So overall, throughout our project, we found that rising ED volumes and transfer rates highlight more of an urgent need to strengthen pediatric capacity in both the Northeast, but then throughout Northern Health. And we know that these transfers are complicated by geographic isolation and limited transport options, which puts additional pressure on providers that are running the EDs, as well as primary care providers in those communities. And so we hope to kind of advocate to expand local pediatric coverage, help improve telehealth links and transportation systems to improve the equity and outcomes for children in the North. And then also just a special shout out to Wanting for helping us with the data analysis.
Great, Leanne. Thanks so much. Does anybody have any questions? You're more than welcome to turn on your microphone and speak if you do, or raise your hand.
I have a question for Leanne.
Sure.
Leanne, my name is Anurag Singh. Great presentation, thank you. Did you look at whether these transfers were like by different kind of medical conditions, particularly medicine versus critical care? Because we don't have ICU coverage for kids in Prince George, even in the region. So did you look into why the children were getting transferred?
Yeah, nice to meet you, by the way. And so, yeah, the the nice thing about the pediatric dashboard is it's broken down kind of by like CTAS, so like triage scores. It was a little bit beyond the scope of what we were looking at in this project. But I do know that sort of we have this improving communication network between BC Children's and sort of the patient transfer network that helps rural pediatricians to decide, and rural care providers in some of those centers that don't have pediatricians, to decide whether it's an ICU level transfer that needs to come to BC Children's, and they help to triage that. So the data is available, and it's something that I think in the future we'll look to sort of expand into why these children are being transferred and if the transfers are appropriate for the condition.
Yeah, thank you. The reason why I was asking was that it makes sense for kids to be transferred directly to BC Children's if they need ICU level care. So I'm almost kind of thinking if the UHNBC pediatrician and the team, they're more stretched because they're getting everything else apart from ICU. So that was helpful. Great presentation. Thank you.
Thanks so much for your question.
Is Evan on the line yet? Evan Hoskins?
Yeah, I made it back.
Oh.
I just had to restart Chrome for some
Okay,
reason.
I saw your message. Okay, so I'm going to back out and the floor is yours. Evan, you're muted.
Okay, that's good. That was all I was kind of saying. Can you hear me? So good morning. My name is Evan J, and I'm a PhD student at UNBC. And today I'm presenting to you on my PhD research proposal with the hope of eliciting constructive feedback from academics and healthcare community professionals like yourselves. So as you can see by my proposal's title there in the top left pink box, my research will explore how Northern literary fiction can help us understand and address Northern health inequities. To do this, my research proposal has 3 questions, which you can read in the bottom left pink box. So question 1 is, what kind of health-related content exists in Northern fiction? And 2, within these texts, what health-related topics emerge as most pressing? And 3, what potential solutions are being explored? Regarding my methods and theoretical frameworks, my study will unfold in 4 steps, which you can read there in the top right pink box. And while I'm creating a list of Northern fiction to study, and feel free to suggest some or put some in the chat, I eventually plan to analyze these texts through Indigenous decolonial theory, eco-criticism, and certainly queer theory as well. Now, I kind of want to use the rest of my time to acknowledge why I think this research is important. Northern communities, especially Northern Indigenous communities, face deep health inequities, often worsened by Southern-centric policies that just don't know or account for Northern life. And for all of you as Northern health specialists, that's likely old news. But I think my research is important because art, in this case realist fiction, does powerful work of spreading knowledge of Northern realities, often in ways that accurately summarize a geographic or temporal breadth of Northern experiences. Furthermore, writers are predictive and inventive people, evident by the many technological and socio-political changes that were first envisioned in books. And while I don't actually know what my research will specifically find, I do believe that literary fiction is a rich and underused source of qualitative data, and if properly studied, can offer incredible insights into Northern health and potentially even offer some solutions to Northern health inequities that are worth pursuing. Now, before the quick question period, I do want to prime you with a bit of a question of my own. Because at the core of my proposed research exists a foundational question that I'm still grappling with. That being, should Northern fiction be studied as qualitative health data? And perhaps wording it another way, I'll ask, do you see art, in this case literary fiction, as a valuable source or valuable resource with a unique ability to shed light on Northern health inequities? Or do you see it as something that, in its very nature of being fictional, has limited potential to help? Or do you see some combination of both of those being true? Or do you just see it through an entirely different lens? So thank you so much for listening. And I invite you to answer this question or any questions in the chat or just with audio. And if you do want to stay in touch, you can scan the little QR code there at the bottom. So thank you.
Thanks so much, Evan. Are there any questions for Evan?
Can I ask a question?
Yes,
Of course. Yeah.
So, hi, Evan. That's a very interesting concept you present there. I'm not a qualitative researcher, but how I work in health research,
Yeah.
predominant clinical research. So what I was I'm trying to learn a little bit about indigenous methodology and research, and what's coming to my mind with your work with fiction is more like the triangulation. So we obviously in the work I do, I use mixed methods.
Yeah.
So we use a combination of both qualitative data and quantitative to understand what's actually going on. But
Yeah.
I was curious if others, and I don't know the literature in this area, have used, triangulation, both using, the real world qualitative data with, fiction to contextualize. It's in the North, there's a lot about remoteness experience, and there is an element of, colonialism. I'm thinking more like a way of analyzing, but if you could look at how it triangulates to the real data that is collected, I think will be very interesting. I'm sure there are commonalities that you will see within fiction, which is written grounded in the North, reflects the real realities with a geography and access and outcomes and so on. So super interesting, very interesting concept. I haven't come across this before. So good luck.
Thank you so much. I would love to ask a whole bunch of follow-up questions, but I won't for time. Thank you.
Thank you both. And Evan, there was a comment in the chat from Senator Martin Harris. She's having issues because of a storm in her location, but she said story work and fiction is important. So, and so our next presenter is Annie Switzer. Pardon me, Switzer. Annie, are you here? Perfect. The floor.
Okay, do you see my notes or just?
We can see your notes now, but we didn't. Yeah, we can see your notes.
Okay. Well,
presenter view.
I might just have to. Joan, I'm just going to wing it then.
Yeah.
Okay, so you didn't see it here? Yeah.
Nope, we can't see your notes.
Okay, because there is no notes. Okay, anyway, thanks. I'm Annie. I'm a medical student at the Northern Medical Program, and I had the great pleasure of being onboarded to this project that was started by Dr. Chewy, who's a radiologist on the right-hand side here, and then Lindsay, who's a clinical practice nurse lead in the imaging department at UHNBC. What our project was looking at was how to increase throughput and the number of patients seen at these ultrasound-guided injection clinics. And what the clinic does, it provides steroid injections to patients that are experiencing pain from tendon and joints and provide symptomatic relief for that with the help of an ultrasound. So what we were trying to tackle was that wait times were approaching up to 30 weeks from the time we were getting the referral to when the patients were injected. Of course, this is not great for the patients who obviously are feeling pain, have reduced functionality, and diminished quality of life. As well, this is not meeting the less than 12-week provincial standard
Annie,
for these types of injections.
We've lost your we can't hear you anymore.
Hello?
I can hear Annie.
Oh.
As can I. Yeah, I can hear you.
Oh no. Okay, well, I'll keep going. I don't know what's going on.
Okay.
Okay.
Very sorry.
Okay. Well, thanks for letting me know. I'm sorry, I'm not sure what to do, but I'll keep going. So the aim was to increase our clinic capacity by 100% by June 2025. To do this, we started with the 5S Lean methodology, which is a method that was originating in Japan at Toyota to improve workplace efficiency and reduce waste. And we also used 3 PDSA cycles. So the first one was in May 2024, where we started to standardize equipment, carts, and trays and reduce booking times. The second one, we started to preload ultrasound machine with the patient information and standardize the patient positioning for common injections. And then the last one is where we batch booked by joint type. We're looking at 2 outcome measures. Mainly was the clinic volume, so the number of patients that we're seeing per clinic, as well as the wait times and days from referral to injection time. Our results were actually exciting. I'll draw your attention to the bottom graph here at clinic capacity. So before intervention, we were averaging 4.6 patients per clinic, and after interventions, it bumped up to 9.8. So we did almost double our clinic capacity. The top graph here is projected wait time. So unfortunately, our wait times actually increased from just over 16 to almost 19 weeks. However, we projected that without our interventions, they would increase to 55 weeks by the end of this year. So we didn't meet our target yet, but we did reduce an exponential increase. So the key takeaways are: one, that simple low-cost changes nearly doubled our clinic capacity. Two, we prevented wait times from rising to critical levels, even though we didn't yet meet our targets. And three, using the 5S methodology and PDSA cycles, we were able to create efficient, standardized workflows that we think are sustainable and easy to replicate. So that's it. I'll open it up to any questions.
Thank you, Annie. Does anyone have any questions for Annie? Well, I have a quick question, Annie. Do you guys have any plans for next steps in your project? Or perhaps not your project. Are there any ideas for continuing this work?
Yeah, that's a good question. I am not totally sure, but I know that they did onboard another radiologist and it has been tackling some of those wait times. So that's probably one thing. But I think Dr. Chewy's on the call here. So if you are continuing this project and I don't know, please jump in.
Sure. Hi, sorry, Share Chewy here. I'm a radiologist who's also involved in that project. Thank you, Annie, for that presentation. Yes, the project has wrapped, and we did meet our goal, and actually we think there might be some room for some further improvement, actually. And we're looking at maybe introducing a couple of other PDSAs in there as well. But Annie is correct. We've also brought in another radiologist who has capability to do these injections as well. So that's also brought the wait times right down. So we're actually in quite a good position at the moment to be able to trial a few different things. But yeah, 100, almost 100% improvement actually was almost a surprise to us that we managed to do it actually quite quickly. And I actually think there's a bit more in there. So we're going to watch this space.
Thank you so much. Thank you both. Okay. Our next speaker is Jaimee Feldstein. Hi, Jaimee. I'm gonna let you take the floor.
Thanks, Leanna. Let's see if I can share. Are you able to see my slide? No.
Yes, we can.
Perfect. So good morning, everyone. My name is Jaimee Feldstein. I'm the director for professional practice, nursing and minimum nurse-patient ratios here at Northern Health. So you're probably wondering, why am I looking at squirrel photos? I'll admit first that how much I love squirrels, but on a more serious note, the squirrel carries rich symbolic meaning in various Indigenous cultures. It's a bit silly, but it's also part of how we connect. Somewhere between the laughter and the learning, the idea took shape for what I hope to bring you a memorable 3-minute presentation. Because when we feel safe enough to be playful, we open space for curiosity, creativity, and connection. And that's where the squirrel comes in. This story doesn't begin in my corporate office workspace, but in the forest. As I explored the roots of our work in professional practice through the lens of a quality practice and learning environment and the conversations that shaped it, I found myself returning again and again to the metaphor of the tree, not just as a symbol, but as a living system, rooted in values, branching into relationships, and reaching towards growth. Here enters the squirrel. This tiny creature becomes our guide, curious, collaborative, and always climbing. It reminds us that leadership isn't just about rising to the top. It's about building nests of support, sharing space, and connecting branches. In the North, nature isn't just a backdrop, it's a teacher. Our forests are woven into the way we live, lead, and learn. As our professional practice processes continue to mature, we're beginning to see how deeply they mirror the forest's wisdom, layered, relational, and resilient. Over the next few minutes, I'll walk you through this evolving professional practice strategy, inviting you to see how we nurture leadership, not just through structure, but through connection, care, and community. Planting the sapling and why this matters. So you'll see the photo of the squirrel gently planting a seedling. Let's begin with why this work matters. Novice leaders are full of potential. Professional practice nurtures their growth from the very beginning. In complex care environments, novice leaders are often thrown into high-stakes situations with limited support. The result, stress, uncertainty, and sometimes burnout. We know that safe, confident leadership is essential, not just for team cohesion, but for patient outcomes. Exploring the trunk and the gap we're addressing, the squirrel discovers a hollow in the tree. There's a space in leadership development that professional practice fills. In building leaders, professional practice ensures that they're ready for the realities of care. Right now, there is a gap. Novice leaders need support that's grounded in regulatory literacy, ethical decision-making, and the nuances of clinical practice. And that's where we come in. Building the nest in our approach. The squirrel gathers twigs and builds a cozy nest. Our strategy is built on 3 pillars: mentorship, regulatory literacy, and empathy. We're designing a framework that's relational, not just instructional, and creating a safe and structured environment for learning. So it's about helping new leaders navigate complexity with confidence and compassion. Sharing the tree, empathy, and leadership. The squirrel shares space and acorns with other forest creatures. Empathy isn't soft, it's strategic. Research shows that empathetic leaders foster psychological safety, reduce turnover, and improve team performance. In our model, empathy is a core competency and not an optional trait. It fosters collaboration, psychological safety, and ethical decision-making, core to quality practice learning environments. Connecting branches and organizational alignment. The squirrel links 2 trees with a vine bridge. This isn't duplication, it's integration. We're working alongside other organizational partners like organizational development, human resources, etc., to ensure our strategy complements existing leadership programs. Our focus is on the practice environment where leadership meets care. And finally, reaching the canopy, what's next? The squirrel climbs to the top and waves to others. So what is next? The strategy is still in development, and we want to co-create it with those who live the realities of care every day, with the goal to create a leadership culture rooted in ethics and quality, 1 branch at a time. As you've seen, this framework isn't just about supporting novice leaders, it's about growing something meaningful together. It's being built by a professional practice team that is itself learning, evolving, and finding its footing. And it's intentionally multidimensional, designed to orient new leaders, offer education and support along the continuum, and walk alongside leaders in complex practice consultations. Thank you.
Thank you, Jaimee. We are at time, so rather than take any questions, I'm going to move on to the next presenter, but please, if anybody wants to ask anything of Jaimee, please put it in the chat and you guys can continue there. Okay.
Thank you.
Really interesting, and I love squirrels too, so I like your pictures. Kate Neithammer.
Hi.
I'm sorry if I mispronounced.
No, you did it perfect. You did it perfectly.
Okay.
Let me share my screen. Let me remember what I'm supposed to be doing here.
What matters most?
Yeah.
Maternity.
I remember that part. I'm just, it's more the sharing of the slides. Yes, thank you. Good morning. I will talk fast, so I'll make this fast. I did a quality improvement project on what matters to Bulkley Valley District Hospital maternity nurses. So that's here in Smithers. And so a little bit about the project. To be honest, this project started as a lot of complaining. In 2023, our maternity department was not doing well. We were short-staffed. We were having to go on diversion very frequently. So I was complaining, the nurses were complaining, administration was complaining. We had 21 maternity trained nurses in our community, and only a handful of them were willing to work on our maternity ward. So it was very frustrating. And I went to lots of meetings to see what we can do to fix. And finally, a friend said, why don't you do a quality improvement project to see if we can figure out more of what the issue is going on? Because I realized I can't change union contracts or Northern Health finances or anything like that. So the kind of fundamental of QI is asking questions. So I started my project with an anonymous questionnaire for the maternity nurses on what they liked about their jobs, what they didn't like about their jobs, and what they were hoping could change. And so what it came down to is they like feeling connected with their coworkers and the doctors that they work with. They don't like working alone. So we have had one maternity nurse on the ward historically, and that's been an issue. They wanted hospital scrubs to wear. We had hospital scrubs during COVID. Everyone could wear them. They took those away. And they wanted more learning opportunities. The good news is they did feel supported by each other, and they did feel supported by the doctors they worked with. So the first thing I did is we had a cabin crawl. We got together off of hospital grounds. Anyone that worked in maternity, whether a nurse or a doctor, was invited. We held it up on our local ski hill, and lots of people were able to come. From that gathering, we did another survey to say what went well about it, what didn't, and learned that, up the ski hill is not far, but people that were on shift were unable to come. So we planned another gathering that was in town that spanned over shift change. So it started at 5 and went to 9. So people that were working that day were still able to come. And we had a much better turnout for that one. For the scrubs, I talked to housekeeping and our director of care to say what the issues were, and we did get the issues sorted out, and scrubs were reinstated. And then for the learning, we took volunteers to rotate at UHNBC's NICU, which we historically have done to learn how to care for more acute babies that we potentially might have. And then just very serendipitously throughout my project is there was big changes with nurse-patient ratios and a lot of things that I don't understand. And so then we did end up getting 2 maternity nurses on our unit and have been fully staffed since then. So now my project ended about a year ago, and I'm just in the process of checking back in to see where we're at. So I'm going to be doing another survey to see how we can make more joy at work for our maternity nurses. I did have really good news that I was going to say that we've only been on diversion once this year for staffing issues, but actually on Saturday night we had to go on diversion. But that's okay. We are overall doing really well. We've run into some other financial strains for the learning that traveling for nurses has been limited, but I'm hopeful for it going further. And then I continue to have informal check-ins on our maternity ward to see how nurses are doing with our new staff. And then Bulga Valley District Hospital, we've kind of extended this Joy at Work project to involve our whole hospital, and we do a hospital-wide kudos project that maybe in the future I can tell people about. That is it. Thank you.
Thank you so much. We have time for one question, if anybody hasn't one. And or again, feel free to put some comments in the chat. Very creative and inspiring work. I'm not sure if you have your chat opened, but
I do. Thank you.
It is. I love the pictures too, and those were great ideas. Team building, taking out of the workplace and making it fun. Okay.
You can have fun at work too, though. I don't want. You should have fun at work too.
Okay. Our next presenter is Anurag. Anurag and Lauren Currie.
Anurag's back.
Oh, hi, I'm back, but I'm on my phone, connected to my phone. We just had a power outage, unfortunately.
Oh, okay. Does
Okay,
Lauren
so I'm gonna
okay.
try to share. Okay. Can you see my screen?
It's just coming up now.
Okay.
Yep, there it is.
Okay, so good morning, everyone. My name is Anurag Singh, and I'm presenting here on behalf of Lauren, Ashmita, and the Hybrid Care Research Collaborative. The title is An Interdisciplinary Community Engaged Incubator for Rural Health Equity. Um, so background, why HCRC exists and our objectives. We know communities faced ongoing challenges across the North with access, workflow, culturally safe care. Hybrid care, which combines both in-person and virtual modalities, holds promise to bridge these gaps, which is, culturally grounded, we know, and community-led research. Um, and okay, so HCRC was created as a collaborative network grounded in relationship and Indigenous values. Our two main goals are to co-design research agenda, so not decide what we want to research, work with the communities to decide on what research priorities should be addressed, and then co-create a system level change through trust and mutual learning. So what framework, how we're going to do this work, guided by Pentagram partnership, Pentagram Plus framework, bringing together patients, clinicians, researchers, policy and community partners. So we've been working on that and using the appreciative inquiry, a strength-based approach that builds on what works and invites shared ownership of the work that is done and ensures that the research that is done is grounded in stories, evidence, and lived experience. So what activities? So what we've done so far in the last 2 years that this was created, since 2023, HCRC has built a community-driven platform for hybrid care innovation. We now have 39 active members across academia, practice, community, and policy. We've hosted, one workshop, second workshop actually, this tomorrow actually on Friday. And we've been successful in 4 successful grants, generating a decent amount of funding, and also mentoring medical students and building a learning health system for Northern and Indigenous context. And our next steps really are to evaluate hybrid care implementation and outcomes on her health workforce impact, expand Indigenous and rural participation in research governance and dissemination, and yes, building a learning health system for Northern and Indigenous contexts. I don't have time to go into that, but acknowledging our partner communities, Takla Nation, Gitsala, Hegluet, Tumbler Ridge, Burns Lake, and our dedicated team across UNBC, Northern Health, UBC, and together we're hoping to advance health equity through hybrid care grounded in relationships, reciprocity, and research excellence. Thank you very much. And sorry about the hiccup. I'll stop sharing here. Okay.
Thank you. I'm sorry, I didn't notice the message saying you'd had a hiccup. Does anyone have any questions?
Okay.
Well, I think it's a fantastic project in developing health equity for across the region, and I've been involved a little bit with some people who use hybrid care, and it means a lot to them. So thank you.
Yeah, thank you. Just gonna put myself on mute. Okay.
Okay, there's some messages in the chat. Use of AI in virtual care. Planetary health impacts are high.
Yeah. We should invite you to our workshop. AI is part of this, how we can integrate AI into the workflows.
Can you see the chat? Anurag, there are some messages coming through for you.
Sorry, I can't.
I thought perhaps you couldn't.
My screen is frozen.
Okay, we have 45 seconds. I'll read them out.
Okay.
I believe this is featured on a Quality Cast North podcast. I think that's in reference to the use of AI in virtual care. And apparently it was because somebody sent the link. And an incredible project. No questions right now for me, but so happy to know about it now. And we'll try to stay connected with what's going on. And then Angela asked, what time is the workshop? That was the workshop yesterday, wasn't it? Oh, I can't hear you. Angela, yesterday was our workshop day, and there was one on AI.
Workshop is tomorrow, Angela.
Oh,
It's at UNBC. Yes, Friday all day. So from 8:30 in the morning to 3 p.m. Yeah, we can send you detail. We can put it in the chat.
sure. Okay, I'm sorry. I thought you were referring to the conference workshops. Okay, thanks so much. Next we have Elena Macaron, Tammy Howe, and Avin Sinden. Okay.
Hi. Okay, I'll share my screen. Can you see that okay?
Yes.
Okay. So hi, I'm Elena. I'm a PhD candidate at the School of Audiology and Speech Sciences at UBC. And I'm also a registered speech language pathologist living and working here in Prince George with adults across the healthcare continuum. But my passion is working with people with aphasia. So aphasia is a language impairment that affects the ability to speak, understand others' spoken language, and read and write. People with aphasia are inherently competent, so they know what they want, but the aphasia masks that competence. And it's caused by damage to the language area of the brain, most often as a result of stroke. Currently, there are an estimated to be more than 40,000 people with aphasia post-stroke living in BC. So aphasia camps are community university partnerships that bring people with aphasia, their families, and students from various healthcare professions together in person for a weekend. It's a safe, supportive environment for people with aphasia to try different social and recreational activities. And it also provides an opportunity for healthcare students to learn about aphasia and understand the importance of interprofessional education. In 2020, due to the COVID-19 pandemic, UBC's annual in-person Sea to Sky Aphasia Camp had to quickly adapt and shift to an online camp. So the aim of this study was to explore the experience of participating in that camp from perspectives of different stakeholders. So we used an instrumental qualitative case study design. The written documents provided some context for the study, such as camp schedules, aphasia-friendly materials sent to participants, etc. And semi-structured interviews were completed online with 4 participants. So we had an adult with aphasia, a speech therapy student, a clinical lead, and a camp organizer. Qualitative content analysis identified 5 overlapping themes. So the first was social connections. So just that opportunity to meet other people with aphasia, share stories, and connect. It was also thought to be a safe space. So this is the concept that people with aphasia need supported places, like a facilitated space where they can connect and participate in activities and have conversations. It's also noted it's not as natural. As we know online, you can't have side conversations with one person, so you can't necessarily talk to the one person you might want to. It's also noted there's a lot of talking, not as much doing. So there was lots of facilitated conversation in the online camp compared to in-person camps where there are no conversation groups. Conversation just naturally happens during meals together or walking to play bocce or something like that. And then the logistics of online delivery. So there was a lot of new things to consider. Zoom was very new at that time, and so there was a lot to sort out. But overall, with the onset of the pandemic, this prompted providers to expand their services for our folks with aphasia to include online options, many of which have continued since the pandemic. And these findings can help inform the development of future online programs for people with aphasia post-stroke. That's it.
Thank you. Does anybody have any questions or comments?
I think I might have missed. I was wondering what the time frame was for this.
For the camp. So the online camp was held in September 2020. And so the in-person camps were usually Friday afternoon to Sunday afternoon. So this one had to be adjusted. It was all on Zoom. So it's Friday night for 2.5 hours. And then on the Saturday for, I believe, 4 hours. and Sunday for about 3.5. That was for the participants, but the clinical leads, camp organizers, and students were on there for several hours extra before, having pre-meetings and debriefings afterwards. So they were quite long days.
Thank you.
Yeah.
All right. Well, thank you so much, Elena.
Thanks.
So I just want to thank everyone again, all of the presenters, the audience, and the next session starts at 11:05. If anybody's having difficulties getting onto Feedloop, if you go to UNBC at the Health Research Institute at UNBC, we have all the links for all the sessions there as well. So
Sorry, Leanne, it's Anurag. I believe there is another presentation that was on the list that Lauren is doing.
was there? Okay. I'm sorry, I don't have it on my list. Lauren, I apologize. Please go ahead.
I will try to be brief so as not to take up more time.
No, we have the time. I apologize. You weren't listed here. So
okay. Crystal just got cut off.
Okay.
Hi everyone, I'm Lauren. So what I'll talk about builds very closely on what Anurag was speaking of. So as part of the HCRC work that he spoke about, we received a CIHR grant to study the implementation of hybrid care, particularly as it is able to address health workforce related issues. And so one of the things that we've done in advance of as part of this work is to do a rapid review of what the literature has to say about how hybrid care, as we understand it, can impact health equity. There is a limited amount of literature currently published, so this is an emerging area that has really kind of come about since COVID in any sort of real way. But the literature that does exist does kind of fairly strongly support what we believe it does, that this model can transform and reduce certain barriers to accessing healthcare for people in rural, remote, and Indigenous communities, as well as addressing health workforce issues in terms of kind of supporting providers that are providing care in these communities, as well as providing virtual support when providers are absent. So there are some good examples that kind of map fairly closely to how we envision hybrid care from Ontario and Australia. However, a caution that is also out there is that without addressing infrastructure related challenges and the digital divide, that we risk reinforcing cultural inequities and not appropriately addressing cultural safety for Indigenous communities in particular. So that's something that we're keeping in mind in our work. Hybrid care proposes many opportunities for addressing challenges in accessing healthcare for people in these communities. It can promote continuity of care. It helps to build trust when there's a relational aspect to the care where individuals are not just having one-off encounters with a virtual provider and then never hearing or seeing them again. Studies have shown that it does increase provider satisfaction and user satisfaction, but there does need to be kind of training around this on both ends for people to be comfortable with the technology. So again, the caution and what we are taking into our work is trying to ensure that there's cultural safety built into anything that does get implemented in these communities, that we are developing this approach to hybrid care in a relationship-based way that keeps in mind that we can't lose that in-person connection as well. So, and that's what we've been hearing in kind of our preliminary community engagement activities that we've been doing for this study. So just some of the main takeaways in order for hybrid care to actually work in these contexts. It needs to be relationship-based and not just one-off encounters. We need to improve people's digital literacy and support them in that process, as well as recognizing that infrastructure can be a challenge. And so finding ways to overcome those challenges is important. But we do believe strongly that with community input and co-design in developing the approach for different communities, that it can be a way to improve access and ultimately healthcare outcomes for patients in these communities. And same thank you slide, because it's all the same people involved in this study, and I will stop there.
Thank you, Lauren. Does anyone have any questions for Lauren? Okay, very interesting work. Again, that's just it to Anurag. Okay. Well, apologies again for missing Lauren. I just double checked in feed loop and it was a copy paste error for our calendar invite that we missed you off there.
No worries.
Okay. All right. We have some things in the chat. Thank you. Important work and an important subject to reduce healthcare inequality or inequity, pardon me. All right, everybody. So I am going to bring this session to a close. And again, thank you, everybody, for presenting here today. And I hope you attend the further sessions for the conference.